Hello and welcome to this session of Center for Podiatric Education. In this session, I'd like to talk about principles that have been established for fracture management in the geriatric patient. As podiatric physicians and surgeons, we are seeing more and more elderly patients, and it's always been interesting to me that we have all sorts of affiliated organizations, pediatrics and so forth. And the one affiliated organization we really don't have in podiatry, interestingly enough, is an organization dedicated to evaluation and management of the geriatric patient. And certainly podiatry has always been intimately involved in management of older patients. So the question is really, do we treat fractures differently in the older patient than we do the younger patient? Certainly we do see some circumstances that are different, as we do in our Fred Flintstone buddy here. The purpose of this lecture is not to establish firm guidelines and principles that must be adhered to, but rather to get you to think about special considerations that do occur in the older patient. This quote by Socrates was really not that much removed from quotes of the great scientist and educator James Ganley, who always would tell us as students that as a teacher he could never teach us a subject, that it was up to the individual to go out and learn about that subject, and it was the job of the teacher to teach the student the importance of learning about a particular subject and motivate that student to go out and indeed go and learn about that subject. So we know that fractures are common in the elderly patients, and fractures of the ankle in particular, a bit more so than the foot, are reported as being quite common in the elderly patient. When it comes to fractures of the hip and cranial and spinal trauma, of course, we enter the specter of mortality. With reference to morbidity, there are millions of fractures that occur in the geriatric patient on a year-to-year basis, and it's estimated that on a year-to-year basis, about 1 in 4 elderly patients fall. If we look at data that's available to us, we know that there is an increasing risk of ankle fractures in the elderly patient being reported. Fragility fractures are frequently associated with these, and this can make the reduction and fixation of such fractures extremely difficult. We see this in the elderly patients because as we get older, there's an increased propensity to fall. A number of studies have shown that these falls are more common in patients who are larger and have increased BMIs. And we do see the effects of medications in these patients, in that we see problems such as orthostatic hypotension and visual difficulties and so forth contributing to these falls. And it's important that when we do treat patients for these injuries, that we try to assess risk factors that might have been operative in the cause of these injuries, so that we may recommend modifications in lifestyle, perhaps reconsideration of certain medications and so forth, in an effort to prevent these falls from occurring again. If I were to summarize the literature on geriatric fracture management, the optimal treatment is not all that clear. Obviously, there is a much greater depth of literature for fractures such as hip fracture than there is for ankle and certainly for foot fractures. If we look at the literature available to us with reference to the foot and ankle, open reduction and internal fixation for displaced fractures is still generally advocated, and for the average patient, the mere fact that they are older does not contradict open reduction and internal fixation. Whenever we go into fracture reduction and fixation in the older patient, I think it's important to remember that osteoporosis may make effective fixation difficult, And you want to always go into this fracture with a variety of fixation approaches in mind and think to yourself, if my primary mode of reduction and fixation is not going to prove to be sufficient, what are the alternatives that I would consider and have those available to me. Up to the year 2000, there's been at least a threefold increase in reported fractures in the elderly patients, and it's said that there are about 8.3 fractures per 1,000 Medicare recipients. Oftentimes when we see fractures in the older patients, there's quite a bit of comminution secondary to osteopenia and osteoporosis, and again, this can make fixation and the holding of that fixation quite difficult. And we know that osteoporosis, as perhaps suggested in this cartoon, is not at all uncommon in the older patient. If we look at osteoporosis with aging, we know that both men and women do lose bone with aging. This is more accentuated, as you all probably know, in the female patient secondary to postmenopausal effects and associated endocrine effects, but decreasing bone mass also occurs in our male patients in addition. Again, when we see these fractures and look at x-rays, we realize that oftentimes there is quite a degree of osteopenia present, and we have to think to ourselves, what are we going to do to maintain that reduction and maintain that fixation in an effective manner? Because osteoporosis, when it is present, where we see quite a bit of loss of medullary bone and cortical bone, we know that going in, these are going to be difficult reductions to hold. And again, we want to familiarize ourselves with alternative fracture management techniques and have these alternatives available to us. Looking at some of the studies that are available, particularly in the area of ankle fractures, you see diverse opinions. The Seeley study looked at 9,704 women over the age of 65 and attempted to identify risk factors for fracture. And the most common risk factors identified included a history of instability and prior falling, patients that have difficulty with the get up and go test, and we'll be discussing that in later sessions, but this is a relatively simple test that one can do in the office that can predict the tendency toward falling, strenuous physical activity, or conversely a sedentary lifestyle, and overweight status are all identified as potential risk factors. Interestingly enough, the risk factors for fractures in older women were different from risk factors found in patients who have osteoporotic fragility fractures that are typically seen in other areas. The Greenfield study looked at 103 women over the age of 50 with ankle fractures and compared those patients with 375 patients who were female but did not have an ankle fracture. The major risk factor was found to be a higher BMI. Interestingly, the Greenfield study found no difference in bone mineral density between patient groups, that is to say ankle fractures in the older women. And again, as the Seeley study, they felt that these ankle fractures which were encountered were not typical fragility fractures due to osteoporosis. The Valtola study was a rather large study, again looking at patients and ankle fractures with identified risk factors including overweight status, polypharmacy, again as in the Seeley study, a history of prior fractures, and cigarette smoking, and found a definite relationship between cigarette smoking and fracture risk. Our orthopedic colleagues have developed a concept of orthogeriatrics, and we used to hear the term, at least I did early in my career, podogeriatrics, and somehow that's disappeared, and I'm not sure why. We have, podopediatrics, we have individuals who claim expertise in wound care and diabetes and so forth, and yet we don't see a real exploration of the geriatric patient amongst podiatrists, and yet I venture to say that many podiatrists, particularly in private practice, have a waiting room full of older patients. We know that with aging, the perioperative risk does increase, And this is due not only to the presence of comorbid conditions, but also there's increased surgery and anesthesia risk. And again, for that reason, it's important to take our time to really evaluate these patients carefully prior to surgery and carefully weighing the risks and potential benefits of open reduction and internal fixation, because we do know that perioperative risk is increased in the older patient. And I would suggest that a little bit more care be taken to evaluate these patients for risk factors, taking our time, looking up at that patient rather than just at their foot or their ankle, considering necessary preoperative testing, looking at the perioperative management of the drugs which they may be taken, and considering again whether or not surgery is indicated. And if, in your opinion, surgery is indicated, recognizing that the geriatric patient is at increased risk for complications, I think it's wise to document a stronger indication for the surgery so that anyone reviewing your decision would understand the rationale upon which you went ahead and decided to proceed. The average patient over the age of 70 has 5 comorbid conditions for which they're being treated, and many of these do require consideration in the perioperative setting. Certainly coronary artery disease, one must consider the anesthesia risk, the post-op rehabilitation risk, and consider when appropriate cardiac consultation. Dementia is present in a large number of patients over the age of 30, and again, this may make the following of post-operative instructions more difficult and may force us to entail additional parties to assist in the recovery of our older patients. And we need to look at those patients, consider this prior to surgery, and meet with the family when they're available and enlist them to assist in post-operative care. Again, falls following surgery are not uncommon in the older patients, particularly if we've got them in a cast or a boot or using crutches and this type of thing. Hearing loss is not at all an uncommon comorbid condition. Another one contributing to potential problems in rehabilitation would be visual loss. Cancer in and of itself is not problematic for healing of foot and ankle fractures. However, the effects of chemotherapeutic agents and the fact that some of these patients may have neuropathy from their chemotherapeutic agents, and we know that neuropathy is associated with increased risk of operative complications. Diabetes, of course, is present in about 20% of our elderly patients, and glucose intolerance and prediabetes, of course, present in at least twice that number of patients, if not more. And diabetes itself is associated with some problems in bone healing, associated with vascular disease, associated with neuropathy, and there are increased difficulties in healing of bone in the diabetic patient, which we'll discuss later. And again, issues such as congestive heart failure, cardiac failure, and so forth. So looking at patients who are older and are prone to falling, we need to look at that patient generally and work that patient up for these comorbid conditions, determine which of these comorbid conditions are potentially life-threatening and which of these comorbid conditions can affect bone healing, how they can affect the ability of the patient to assist in rehabilitation. So with the elderly patient, this concept of orthogeriatrics or podogeriatrics, if you will, is extremely important because we all want the best outcome for our patients, and at times, again, we must look beyond that foot itself. What about open reduction and internal fixation versus conservative care for ankle fractures in the geriatric patient? There are quite a number of papers that have examined this issue. The Beauchamp paper looked at about 126 patients who are older than 50 years old with ankle fractures, and we looked at patients who are treated with open reduction internal fixation versus cast immobilization. And following the treatment in both groups, about 2 years Later, there was not a significant difference in symptomatology or range of motion. However, as you would imagine, the operative group did have an increased incidence of complications associated with the surgery. The ALI group looked at 100 patients who were greater than 60 years of age with ankle fractures, and again, 50 treated non-operatively, 50 were treated operatively. Obviously, you would imagine and was confirmed that there was a higher rate of malunion and non-union after conservative care, and that patient satisfaction, at least in the ALI group, was greater with operative intervention. The SALI group, 84 patients greater than 65 years of age with displaced ankle fractures. A few of the patients, 16, were treated conservatively, 49 treated operatively. And at 3 years, there was a higher AOFAS score in the non-operative patient cohort. However, you have to consider the fact that the fractures treated non-operatively were less morbid fractures in this study. About 1/3 of the patients did require removal of hardware. The Makwana study was that of 47 patients over the age of 55 with ankle fractures. 21 were treated operatively, 22 non-operatively. The patients who were treated operatively had higher functional outcome scores with less swelling and better range of motion than those who were treated non-operatively. However, again, as you'd imagine, the surgical group was associated with a higher rate of complications. 74 patients older than 70 with ankle fractures, all treated by open reduction and internal fixation, and 84% of the patients returned to their preambulatory status. The Pagliaro study was a small study, 23 patients over the age of 65 with displaced ankle fractures, all of whom underwent open reduction and internal fixation, with union achieved in all of the patients, and unfortunately, significant complications leading to amputation in 2 patients, which would be about 11%. The Davidovich study, 56 patients older than 60 with ankle fractures. And in this study, the authors looked at or compared fracture healing and outcomes in older patients versus patients younger than 60, all of whom underwent ORIF. And as you'd imagine, consistent with your thinking, there was a slower rate of functional recovery in the older patients. However, steady improvement was shown over time. So certainly these studies indicate no firm demand for either conservative care or open reduction and internal fixation. And both non-operative and operative interventions are well supported in the studies that are available. Looking at the complications in doing open reduction internal fixation of ankle fractures in the older patient, removal of screws and not at all uncommon, irritation from plasters, casts and immobilization devices, not at all uncommon, and wound complications with wound breakdown, wound dehiscence being the most common complications at all. But the complication rates, really looking at these studies, is not particularly extraordinary and certainly does not demand reconsideration of ORIF in patients. Looking at ankle fractures in general by a review of Medicare data, men seem to be at greater risk for complications than women. And after the initial month, non-operative care actually is associated with higher mortality than operative care. And as you could see, non-operative care was associated with 9.2% mortality compared to 6.7% at 1 year and 16.9% for non-operative managed patients versus 11.3% in patients who underwent surgery. As we look at this data, several trends become clear. Operative cases are associated with a higher rehospitalization rate at all times following ORIF, most commonly for removal of hardware, loss of fixation, and the need for revision and additional fixation, or the eventual need for arthrodesis or amputation. The rehospitalization rate is greatest in the first month. And I think the most important takeaway from all of this is that when we enter treatment of fractures in the older patient, we need to realize the complication rates and sequelae, such as the need to remove hardware. These rates are much higher in the older patient and doesn't represent poor care, but goes along with management of ankle fractures in the elderly. Again, this particular review looking at complications in the management of ankle fractures in the elderly. Most of the surgical problems in this particular study were attributed to the presence of osteoporosis. Again, reminding us to enter the operating room with alternative approaches to treatment in mind. Oftentimes there was insufficient screw purchase and loss of reduction, wound breakdowns and infections, and the need for extended non-weight bearing, again, problematic in the elderly patient. So when we entered that operating room, we want to remember that stable constructs, stable reduction maintenance is not always easy to obtain in the older patient. In this particular study of 37 Weber B fractures, strip screws were augmented with bone void fillers, and if one has the sense that there's significant comminution and or osteopenia, it is good to have some orthobiologic agent available to assist us in filling the voids and helping to gain better purchase of our screws. In this particular study, all 37 of the ankle fractures healed, and by utilizing bone void fillers when necessary, all the patients healed at 2 years without loosening of the screws. Another more recent study looking at 216 ankle fractures in older patients, and interestingly enough, there was no statistically significant difference in comorbidity versus no comorbidity patients in terms of healing. Again, as becomes a common theme in many of these studies, wound healing problems are the most difficult situation, most common situation. Complication rates increased with increasing age and diabetes, but in this particular study were not significantly different. Although we hear a great deal of advocates for locking plates in the elderly patients because of osteopenia, in this particular study, which was rather robust at 216 patients, there really was no difference in healing between locking and non-locking plates, and there was no difference with early ambulation versus delayed ambulation. The Leach study was 76 patients greater than 50 years of age, an acceptable infection rate, and here again wound healing problems were common, and a reasonable or acceptable rate of malunion, which typically was associated with inability to hold reduction or to maintain fixation. In general, ORIF is used for foot and ankle fractures. In looking at this review of 294 high energy fractures of the foot, 83% of the patients underwent open reduction and internal fixation, and the authors reported no difference in complication rate between the older patient and the younger patient. Others have reported some increased complication rate in older patients versus younger patients. This was a study looking at isolated ankle malleolar fractures over the age of 60, reporting a considerable complication rate of 40% versus 11% in the older patient, but no difference in eventual long-term outcome. So when we go into that operating room to treat a fracture of the foot or fracture of the ankle, we want to keep several things in mind. We want to enter with alternative fixation devices available to us. This may range from external fixators to Steinmann pins, various types of plates and so forth, and you want to have alternative fixation in mind and available should they be needed. You want to request and have available bone void fillers, as you may require some orthobiologic. There are some who have again strongly advocated the use of locking plates in the presence of osteopenia when you do your open reduction and internal fixation, particularly when there is clinical evidence of poor bone health. You probably want to use longer plates and purchase more cortices than you normally would for the same fracture in younger patients with good, hard, stable bone. so the use of additional hardware is not at all uncommon. You want to immobilize these patients for longer periods of time. You want to engage in splinting and bracing more commonly than you would the younger patient, and again with more prolonged non-weight bearing. You want to consider supplementation of the osteopenic patient with calcium and vitamin D. You probably want to avoid the use of anti-inflammatories, as this may be associated with delayed bone healing and impairment of bone healing in the elderly patient. And you might look at that patient generally and consider more general nutritional supplementation. Newer thoughts in the geriatric patient include increasing enthusiasm for minimal incision techniques, the use of intramedullary fixation for malleolar fractures, perhaps the use of external fixation in the presence of significant comminution or under other particular circumstances. As I've mentioned, there are those who advocate locking plates, so that the ideal fixation for any particular patient is obviously dependent on a case-to-case basis, recognizing that failure to maintain fixation is not malpractice. It is something that occurs on a fairly regular basis. In regard to this issue of decreased bone mineral density and the use of supplementation, we're generally looking at recommendations for calcium between 1 gram and 1.5 grams per day. Vitamin D somewhere in the 400 to 800 international unit per day. Obviously, post-fracture, we cannot have the patient immediately exercising, but as soon as we can get them mobile or maintaining active range of motion, this will be helpful. And looking at the patient generally and seeing if there are any fall risk prevention strategies that we can recommend to the patient, looking at their living environment, asking some questions about whether or not there needs to be some modification in their lifestyle, so that we do see the need to look at these patients and try to prevent additional falls and injuries in the future. This is something that is a real contribution that we as podiatric physicians and surgeons can make. There are simple questions you could ask recommended by the CDC. Number one, have you fallen in the past year? Number two, do you feel unsteady when standing and walking? And number three, do you worry about falling? This is not at all an uncommon problem with the elderly, preventing them from being active in the community. That is to say, once they have that initial fall, there's a tremendous fear of falling again. You might look at some of their medications, or perhaps communicate to the primary care physician or other treating healthcare providers that perhaps some of their medications may be operative in predisposing these patients to falls, and again recommending calcium and vitamin D. Again, the appropriate referral to physical therapy and training for gait assistance, utilizing any of a variety of gait assistive devices, is something that we do on an individual basis. Who does and who does not do well following fractures in the elderly patient? Patients who are more likely to do well have normal cognitive function. They tend to be more healthy, independent elderly. There are those who don't have a great deal of comorbid conditions and have a normal life expectancy. They tend to be more active into their later years, both socially and mentally. They have a lower body mass index, and they're more involved in health care for themselves. Those patients who are less likely to perform well following fracture management include those who have cognitive impairment, patients with multiple comorbid conditions, patients who have conditions with which limited life expectancy is associated, patients who are generally housebound, who are morbidly obese and appear not to care for themselves. And once again, as a podiatric physician and surgeon, we certainly can look at these patients and assess them easily enough for these factors. And when the factors are present that would predict poor performance, perhaps getting them more physical therapy, more gait training, pay more attention to gait-assisted devices, and recruit others to help assist in rehabilitation of these patients, so that a variety of problems do occur in these patients. And again, things such as loss of fixation, requiring revision surgery and so forth are not at all uncommon. In the presence of severe osteopenia, at times the use of multiple Steinmann pins is more than acceptable for the treatment of many of these fractures where there's severe osteopenia, the patient is medically compromised, and is not a candidate for more aggressive fixation techniques. So looking at the elderly patient, the same factors apply for treatment of their fractures as apply for treatment of fractures in younger patients. The difference being we need to look more carefully at these patients for risk factors for additional comorbid conditions. I thank you for joining us for this session in the Center for Podiatric Education. Hopefully this will motivate you to want to go ahead and think a little bit about looking at patients in terms of treating fractures in the older patient. Lastly, we want to remember that there's an increased incidence of fractures in these patients, and treatment does need to be individualized. I see a lot of writing about teaching and about how to be an effective lecturer, how to be an effective teacher. And again, I go back to some of the teachers that I had in my life that motivated me to want to be involved in postgraduate education. Maybe one day I'll do a tape on why I always wanted to be a science teacher. And indeed I did. And as I sit here reviewing all this data at the age of 70, I could still recall the names of all those who motivated me to want to become a teacher, and thinking about their characteristics. And has been said by others, to teach effectively, a teacher must develop a feeling for the subject. He cannot make his student sense its vitality if he does not sense it himself. He cannot share his enthusiasm when he has no enthusiasm to share. How he makes his point may be as important as the point he makes. He must personally feel it to be important. And indeed, I feel that we need to have greater involvement in management of the geriatric patient. Thank you.